We'll get started in just a moment. Well, welcome, everyone. I'm Michael Morella, Managing Editor of Events at U.S. News and World Report. As the demand for behavioral health services rises, healthcare providers are looking for ways to ensure that young people have access to the most effective care for their needs. Virtual care has become a vital tool for neuropsychologists and other care providers to treat kids with a wide range of conditions that affect their brain and development. In today's virtual event, I'm excited to dive into this topic with a panel of experts who are going to share their insights on what's working and how to navigate questions and challenges around technology, insurance coverage, privacy, access, and more. Our thanks to Children's Health for their support of today's program. You can find more details about our event, including full bios of the speakers and information about upcoming programs at usnews.com/events. In the coming days, video from today's session will also be archived there as well. I also encourage you to visit usnews.com and dive into the wealth of content around our US News Best Children's Hospitals rankings, which were released last week. Our latest rankings measure pediatric institutions across 11 different specialties, and this was the second year that we spotlighted the best children's hospitals for pediatric and adolescent behavioral health. I'm very pleased that we have representatives from 3 of those institutions with us here today. Now, to welcome those panelists, I'm very pleased to introduce Dr. Jonathan Comer, Professor of Psychology and Psychiatry and Director of the Mental Health Interventions and Novel Therapeutics, or MINT program at Florida International University. Dr. Lana Harder, Chief Neuropsychologist and Director of Neuropsychology Service at Children's Health in Dallas, as well as a Professor of Psychiatry and Neurology at UT Southwestern. Dr. Joyce Nolan Harrison, Associate Professor of Psychiatry at the Johns Hopkins University School of Medicine, and a child and adolescent psychiatrist at the Center for Developmental Behavioral Health at Kennedy Krieger Institute. And Dr. Erin Sadler, a psychologist in the Division of Psychology and Behavioral Health and co-director of the Mood and Trauma Disorders Program at Children's National in Washington, D.C., as well as a clinical associate professor of pediatrics at the George Washington University School of Medicine and Health Sciences. Thank you all so much for being with us today. Before we dive in, just one note to those of you who are with us live. We do want to hear from you. And so as you have questions during the course of the hour, please type them into the Q&A feature in Zoom on your screen. Our team will review, and I'll do my best to give voice to those that I can over the course of the hour. Now let's get into it. Panelists, we heard a little bit about your roles and the institutions you work at, but I wonder if you could just talk a little more about those positions and the kind of individuals you work with on a day-to-day basis, the focus of your work and research. John, maybe we could start with you and go around the horn.
Sure. Well, thank you again for having me here today. It's a pleasure to be here. So I direct the Mental Health Interventions and Novel Therapeutics program, the MINT program at Florida International University. Most of my work is with kids affected by anxiety, traumatic stress, irritability, or behavioral challenges. And our programs offer telehealth as well as digital mental health programs that are more self-administered. And in more recent years, we've been doing some AI-based work to provide therapeutic supports as well. A lot of our work is federally funded controlled trials, comparative effectiveness trials, comparing different formats and more modalities versus traditional office-based care as well. And I'm sure we'll get into more of that.
Wonderful. Thanks for being with us. Joyce?
Hi, I'm Joyce Harrison. So I am a child and adolescent psychiatrist, but I have a specialty. I'm an infant and preschool psychiatrist. So I'm very interested in early intervention, prevention, and development. My main activity at Kennedy, and the one I think I was invited to talk about today, is being part of Kennedy Krieger's project ECHO. ECHO stands for Extension for Community Healthcare Outcomes, and it is virtual teleconferencing and teleeducation and case-based learning. We have a number of different ECHOs. I'm happy to talk about any of them. We have regional, we have statewide, we have national, and we have international. So that's my main focus, but mainly training pediatricians and early childhood professionals to build their toolkit for doing more behavioral health interventions.
Wonderful. Definitely eager to talk more about Project ECHO later. Thank you for being with us. Lana?
Yes, thanks again for having us today. So as mentioned, I serve as the head of neuropsychology at Children's Health, where I get to oversee a fantastic group of neuropsychologists and trainees serving patients. I actually started my leadership role shortly before the global pandemic, and so had the chance to work with the team. It was a team effort to move things over to a virtual setting pretty quickly. These days, we are using more of a hybrid model, some in-person, more traditional, and then also leveraging our virtual tools. My specialty focus is in the area of rare neuroimmune conditions like pediatric multiple sclerosis. So understanding outcomes associated with those conditions in neuropsychology. And that's actually what led me to pursue research in telehealth, was serving rare populations, wanted to be able to connect with specialty care providers for those who are, scattered across wide areas. So look forward to diving more into that today.
As do I. Thank you, Lana. And Erin.
Hi there, I'm Erin Sadler. As already mentioned, a psychologist at Children's National in DC. My role is, pretty heavily clinical, so a lot of direct service with the subspecialties similar to Joyce. I do have a subspecialty interest in clinical work that I do in early childhood trauma specifically, and do a lot of my work with, I like to say, teens and tots, though I will span the entirety of the childhood, but teens and tots are where I nestle in neatly. I am involved in quite a bit of training at Children's National as well, from all levels of psychologists, so down from our practicum externs all the way up through fellows as well. And then do have some opportunities to crisscross with some of the medical trainees as well through their didactics. So I am super eager to talk a little bit more about how we are including more of a hybrid model similar to Lana as well with some of our service, and in how training can also be included in some of that teleworld as well.
Wonderful. Well, let's jump back in time a little bit, and Lana, maybe we could start with you reflecting on this. Telehealth and virtual care surged during the early days of the COVID-19 pandemic, and it's still something that's obviously connecting a lot of people in healthcare today. I'm fortunate that I can be with all of you and our audience virtually this morning. Before 2020, could you talk a little bit about what your institutions were doing in the virtual care delivery space when it comes to behavioral health, and what some of the kind of biggest takeaways and learnings have been from the last 5.5 years when it comes to this specialty and the range of different conditions and situations that are included under the behavioral health umbrella. Maybe we could start with a focus on kind of children's health and what was going on in Dallas, and then broaden it to the larger group.
Absolutely. Glad to do that. And it's great to reflect and think about what we've learned. We've learned so much in this time period. So prior to the pandemic, we were fortunate that we were exploring this as a group of neuropsychologists, but we were also doing research in this area. And our main question was, is it feasible, would it be valid to conduct assessments over video, thinking about video conferencing, much like we're doing right now, versus what we do in our traditional setting of that in-person one-on-one assessment. Neuropsychologists are known for these big batteries of standardized assessments and have appropriate pause when considering changing anything up about how we administer those standardized measures. So what we learned, and some takeaways, we had finished our data collection before the pandemic, and we're writing it up to publish. So it was a fortunate timing. But what we learned was that when we tested kids in a virtual setting and compared that to our traditional setting, that we did not see any significant differences in the results, which was a great thing, a reassuring thing to know and to see in the data. We did go down as low as age 6, so we had quite a span in age, but it was feasible to do that. And we also learned that this was a satisfactory way to assess based on participants. So the kids themselves told us this, as well as the parents and caregivers. So those were really great things to see as we were all, in an accelerated fashion, moving into virtual space to be able to continue to connect with our kids and families who still needed, and maybe more than ever needed, our support and care at that time. So those are some things that I would highlight, kind of looking back at that time frame.
Others, are there some ways that you're seeing or rethinking about telehealth and virtual care connectivity that have been making a meaningful difference on patient outcomes? I know, there's probably nothing like a one-size-fits-all approach, but I wonder if there are some kind of key takeaways from the sudden pivot or the drastic pivot from several years ago to where things are shaking out now. I know several of you mentioned the kind of hybrid approach. So wonder if that's something someone could expand upon.
I'd like to talk about our shift from pre-COVID to post-COVID and how it's impacted our delivery of behavioral health services. So so everybody knows there's a crisis in child psychiatric healthcare. If anybody's tried to make a referral to a psychiatrist, a child psychiatrist, good luck. You wait 6 months, you wait a year, the child's grown up and improved before they get to the psychiatrist. So anyway, I helped the state of Maryland develop their access program, which is a phone line, and they're now child psychiatry. They call them now child mental health access programs. They're now in like 45 states, where a pediatrician, a pediatric provider who's struggling with behavioral health issues in their practice and not equipped can call and get a consultation, and a de-identified consultation. I set up this program. I worked with pediatricians 5 years across the state, and realized it was kind of limited because I'd have the same people calling me about the same thing. It was sort of knee-jerk. So I had a partner who's a developmental pediatrician. She was sort of my consultant to the pediatricians as that we could when there were developmental concerns, because she's at Kennedy. So we're looking for a different model to help support behavioral health care in pediatric primary care. And we stumbled upon Echo, and we went to Kennedy and said, could you give us money to do this? It's really cheap. You just have to pay us for our time. And they were like, no. We went to the state. They said, sorry. We applied for a federal grant, and HRSA funded us for 4 years to set up an Echo across the state of Maryland in under-resourced areas. So we started that in 2016 when people didn't even know what Zoom was. And so we were doing this telecase conferences and brief educational didactics for people. And then COVID hit, and Kennedy had a small military telehealth program where some psychologists were providing care. And also we had a state autism evaluation teleconferencing, and that was pretty much it, a tele-evaluation. That was pretty much it. Things exploded and everybody went virtual, and they made me chair the telehealth committee because we were the only ones who were doing it and knew how to do it. But what I'm impressed with how Kennedy pivoted and really opened up every kind of service to telehealth. But now what we're finding is, once the crisis was declared over, which, by the way, for child psychiatry, it is not over, it's only beginning, that the idea about doing these virtual visits kind of shrunk. And so we now are forced to do a hybrid, even though we see kids from all over the country, all over the world, because Kennedy's a really highly specialized place. We are fighting, and we're collecting data as well to show that these virtual visits are equally effective. When we have limited resources, people have limited resources to get to care, they really are effective. So we're fighting, we're struggling, but we now are required to see at least once a year in person, whether a person lives in France or down the street. So we're working with that. But that Kennedy just really took the bull by the horns and really made sure that we got the care delivered to our patients during COVID.
I could jump in. So my experience, we'd been doing clinical trials in the telehealth space. We started in about 2007, and it's been really fascinating seeing the sort of shifts in patient attitudes about telehealth, and therapist attitudes about telehealth, and grant reviewer attitudes about telehealth. At the time, there was a sense of, first, is this kind of science fiction, or is this going to work among many? And then the pandemic happened. I'm also the director of the Network for Enhancing Wellness and Disaster Affected Youth, New Day, which is part of the National Child Traumatic Stress Network. And telehealth was really quite a savior for continuing continuity of care and for addressing the increase in mood and behavioral problems among kids during the pandemic. I think what's interesting is telehealth definitely started as, can we expand the reach of care, overcome geographic workforce shortages? But as we're doing more and more research, we're learning that there are other benefits besides just that it can expand the reach, where in some of our clinical trials where we're comparing telehealth to traditional office-based care, telehealth is actually outperforming in some scenarios office-based care. And our thinking is that telehealth can expand the what we call the ecological validity of care. We're treating families in their natural settings, and there's an added benefit for that, working with kids in their natural spaces. And so in that regard, I think some of the most exciting directions of telehealth is when we're not just thinking, can we replicate office-based care at home, but what new does a telehealth format offer us? What new possibilities are there that we couldn't even accomplish in the office? Because it's not like office-based care was already achieving everything we wanted it to achieve if people could get there. So I think when people are thinking of telehealth as part of this larger portfolio of service options or support options, and there are ways in which telehealth may provide better care. There are avenues in which telehealth may not be sufficient for what kids needs, but think about expanding the portfolio and not just focusing on reach, but also expanding the scope and responsivity of care and things like that.
Aaron, do you have anything you would add? And I'd love to sort of, John, as you said, think also in a forward-looking way. What are some of the things that are exciting you about new directions or new dimensions to care delivery?
For sure. I will say, as John was talking and Joyce, I was thinking about what our programming looked like prior to COVID. And at Children's, we're not doing a ton of telehealth. We had a lot of folks in office, but we're slowly but surely kind of weaving it in. Even meetings, we were just barely transitioning to being able to see folks virtually in teleconferences. But similar to Joyce, we were able to actually get a HRSA grant to pilot our telehealth program in our NICU at the time, which allowed us to really expand the scope of services. So primarily seeing caregivers, but for those who were never going to step foot on the actual building space, it allowed us pretty quickly to expand services quite well to folks, like I said, who we might not see ever in the building, and for a myriad of reasons. And then similar, because we are centrally located across jurisdictions, again, families who are coming from far and wide or not able to come from far and wide, we were quickly then able to have folks that would otherwise hope that they could maybe travel to us one day, but maybe not realistically, and then also not have care options elsewhere, that we're able to still be seen. And I would like to think faster than they would. I'm trying to find services locally in person, but again, the crisis is still a crisis.
Yeah, I can appreciate that. And I wonder, thinking about workforce shortages and access challenges, maybe even just starting with those two huge areas, have you found that you're continuing to having to kind of make the case to policymakers, to funders, to clinicians themselves, or to others about hey, telehealth is actually a huge opportunity to connect more, to reach folks who maybe they live 2 miles away, but getting to a clinic is a significant challenge for one reason or several. Wonder if that's something too. Maybe Lana could pick on you, or anyone who wants to jump in on that. Thinking about the sort of access, cost savings, and the opportunity of telehealth to fill the gaps where necessary. Somebody who could maybe connect. Any of you who could connect more times in a day virtually than you may be able to in a clinic or anything like that.
It's a great question, and I'll piggyback off of some of the other comments that have been made. I think it was John that was talking about all of the things we can do for our patient families virtually. We think about a menu of services. So I mentioned earlier, we're known for these, comprehensive evaluations, but certainly not all that neuropsychologists do. And I think that the telehealth environment really lends itself, in addition to, John pointed out, as the natural environment we can observe, we can learn about. We also have the ability to serve, as consultants, to do brief evaluations. We have actually an intake model now that is new since all of this, and we've set up in the last several months, which has our licensed clinical social workers who are trained in neuropsychology and what we're looking for, what we want to understand before moving to that really extensive evaluation that can take, 8+ hours to complete. So the idea behind this is it's a mostly virtual service. We know it, doesn't always work that way for insurance or other reasons, but it is an hour or less to complete on average. And we do a deeper dive into what is needed for this patient that goes beyond what we would learn in a one-page referral form, so that we are making sure to maximize capacity of our neuropsychologists and their practice with these larger evaluations that often are warranted. But we want to understand that we're delivering right-sized care to our patients, and not just moving everyone through based on very minimal information. We just looked at our data recently, and setting this intake service up, when we look at some of the outcomes data, we've seen a 16% increase in utilization of those neuropsychologist evaluation visits, which is fantastic. And speaking of the shortage and all of the challenges that we face, when we know that we're providing that right-sized care, some of those patients, it may suffice to do that brief intake evaluation or briefer service. So we really, really want to think about not only the kind of right-sized care, but kind of a tiered model of care where we're evaluating more kids to determine what they really need, and do we really need the investment for all parties for that lengthier evaluation. So that's been a wonderful thing to have at Children's Health.
I would love to add on to that in thinking about the workforce growth. We're doing it sort of outside of the clinic. I think I'm writing down what you're doing. Like, I think all of these things are great ideas, like the physician extender kind of idea. Like, there, this with specialists, there just aren't enough of us and there will never be enough of us. So what I love about having stumbled on Project Echo is it is a workforce extender, but it's extending the workforce to pediatric primary care, which is where the children are and where the children are presenting with behavioral problems. And it just removes all of the stigma kind of obstacles that don't get kids to our clinic. So it's even one step removed from those people calling for intake to the clinic. And what we do is we hear the pediatricians talk to us about kids. They've made 10 referrals, but they can't find anybody. The family can't get there. They don't take their insurance. The 15 obstacles to those children getting behavioral health care. We hear the case, we make recommendations, we help the pediatrician or someone there's usually a champion in each pediatric office who wants to do behavioral health work. And so we've been gathering data for 10 years with all of these different groups that we've worked with. It's a cohort that we work with, so people learn from every case that's presented. Some of them are weekly, some of them are monthly, some of them are bi-monthly, but everyone learns from every case, including us, about what the pediatricians or the early childhood professionals, now we've expanded to include early childhood mental health clinicians, educators, special educators. So they are better able to identify, yeah, this is a kid who really needs a psychiatrist, or maybe this isn't a kid who needs a so it really just kind of addresses all those other barriers. And we're finding statistical significance of pediatricians managing kids in their office that they wouldn't have if they didn't have the support of the subspecialty. My team consists of a psychiatrist, a psychologist, and a neurodevelopmental pediatrician. So we have all of our heads together and we're trying to figure out these kids. So I think it's the future. And thinking about, our people are finally catching on. we are continually funded through our state, through federal sources. We have HRSA grants, we have SAMHSA grants. Like, they're beginning to get that this really is a solution to address the workforce shortage that we're never gonna. It's only getting worse, right, Erin? You know. So
Yes.
so anyway, I'm sorry, I go on.
No, as we're all chatting, I'm thinking, the need is outpacing our capacity exponentially, is what it feels like.
Yeah.
And similar to Lana, our outpatient department at least has developed a consult model similarly, where again, we've had folks waiting on wait lists for extended periods of time, and there in years past when we were primarily all in person, folks are waiting a year to come to us just to realize that, oh, you actually needed an evaluation of a different sort at a different place. And that's yet another year. And so the virtual world has allowed us to kind of facilitate this process of when folks are referred, we can at least have an initial touch point to make sure they're in the right place. And considering a tiered model similarly around, perhaps we're not needing kind of extensive outpatient therapy, maybe this is something that the school can manage. And so if we can support you in getting back to the school building for this type of support without needing to move for us in order to get that care, it has really made it, I think, a bit of a difference. We're still collecting a lot of that data to see, what it looks like in terms of, our flow, and making sure that we're able to catch folks as soon as we possibly can, a little bit sooner than we did in the past. And one other thing that is, again, kind of somewhat associated that I think about often, again, I do a lot of training, and I have found that in the land of trying to maximize time, that the virtual space has really allowed us to extend training in unique ways where it's very easy for folks to pop into a visit that they don't need to be present in the building for. We can continue to provide, moments for observation where clinicians in training can then get some additional exposure or support. So both on my end as well, I am in one place, I may have trainees that are in a different space that I can continue to provide support for them as well through the virtual world.
I agree with everything that my fellow panelists are saying. I want to echo, I think, what Joyce said about overcoming stigma, about especially working in the mood and anxiety disorders and traumatic stress. People don't always feel comfortable going to a mental health facility, but they're comfortable getting supports in their own home. They're comfortable getting supports in other settings. What's also amazing is when you work with kids, what you really need is all the adults in their lives, the important figures in their lives. And if you can get them all on the same page, you can make some real differences. It was impossible to have a teacher and a parent and a speech therapist, whoever's in the pediatrician. And what telehealth offers is an opportunity for everyone to be in the same room. It's not brick and mortar, but be in the same room and actually put their heads together and coordinate. And that's been a tremendous opportunity. And just one other thing I'll say is the research shows that attendance is better in telehealth. Makes sense, right? That the people are still not on time, right? So it turns out it was never traffic, but they do show up more. They show up for their sessions more. And when I make the argument to hospital administrators, service administrators, that's the number one opportunity that excites them and that encourages them to move toward telehealth, because when patients don't show up, Medicaid doesn't reimburse and other insurance companies don't reimburse. So it's a lost hour. So when you say by letting telehealth come in, you have less lost hours, well, hospital administrators, their ears really, really perk up with that.
I want to go to an audience question because I think it's relevant here, and you all have sort of started to answer it, but just to kind of give voice to it directly. Audience member asks, because interventions or services are best provided in the child's natural setting, which is a child care program in most cases during the day, what can child care program providers do to accommodate telehealth? Is it privacy, ensuring space, assistance? Are there a couple of kind of things that you all could share, or one of you could share to answer this audience member?
Well, I think it's an excellent question, and it also sort of taps into issues of disparities in access to technology and access to private spaces. Sometimes people might technically have the equipment, but they're all in one room, and how could there be a private session? Or other times people large proportions of the population don't have access to the technology needed or to the broadband plan. Uh, so whether that's school settings, whether that's other childcare settings, whether that's public libraries, there's often rooms and spaces that we encourage families to use in order to make when they don't have the equipment at home, or they don't have the plans at home, or they don't have the private spaces at home. Uh, if you can get buy-in from these other settings, it's often a real wonderful opportunity. And in my experience, schools are much more able to give a free room than a hospital is. So schools and public libraries often do have internet rooms you can reserve. So
Thank you.
I,
Joyce.
I would echo Jonathan. I think that is, one of the, and Aaron even mentioned, we're trying to do more services in schools, but I think we in particularly with child mental health, we are very sensitive to confidentiality and privacy. And I think that schools can be, I've done a lot of work in schools. I've seen kids in schools, but schools can be notoriously not good about not sharing information, like, oh, this kid's seeing a psychiatrist or this kid's seeing a therapist. And so that may be one of the barriers. So whatever childcare providers can do to remove that kind of to make sure that the protection of the child's privacy and confidentiality is there. And also the second thing is, Jonathan said earlier, you have to have the family members there. And so seeing a child in a setting where there isn't a significant caregiver present can be challenging. And then teacher, and we have to have consents if the teacher's going to be present in the visit. So it's a little more complicated when you're in the child behavioral health service space because of all the consents and the confidentiality.
Let's stay with that sort of point on challenges and some of the, I can appreciate them, as some of you have already talked about, the care coordination, wonderful, necessary thing that, but a challenging one, whether that's in the clinical setting or at home, at school, in the community, that sort of thing. Erin, I know Children's National has an early childhood behavioral health program that kind of tailors treatment based on individual needs. I think in the spirit of that sort of menu idea that Lana, you mentioned a couple of minutes ago. Erin, could you talk a little bit about that? And maybe that could be a jumping off point to share some other insights on how coordinating this kind of care logistically is, what some of the best practices are there.
Of course, happily. Our early childhood program has done a lot of revamping over the years. We do spend a lot of time, reflecting on the care that we're able to offer. Again, recognizing that wait lists are quite long, and so really trying to think about how we can maximize the care that we are providing. That's also unique to the individual needs of families. The menu it runs quite deep, I'll say, but one of those being, how can we capture more families, knowing that our capacity does not extend. And one of those ways has been virtual group-based settings or services that has allowed us to capture families where we're probably doing a lot of caregiver-driven work anyway. And so why not just go ahead and scoop them up? But I think cohorts of families tend to, allow one another the space to share more freely, get more additional ideas, troubleshoot together. And so I think, again, recognizing that the pandemic did not bring us all necessarily together, where there's a lot of isolation and feeling quite alone in a lot of spaces. And so one of those is providing a lot of group-based services for families. And then similar to the idea of, being able to provide a lot of virtual support with schools, again, knowing that some of those adults that we may need to be working with are in the school setting. And to echo Jonathan as well, school buy-in, childcare buy-in can be magical is the word that actually comes to mind, that if we have the collaboration and the coordination that can really touch a lot of children that we're not even directly seeing. And so that's something that comes to mind for some of us. I know, like I said before, we have a good chunk of families who are coming from far out of the area, and doing our best to think through, again, how we can provide as much access as we possibly can. For some families, we've had the opportunity with some grants previously to extend some additional services around transportation, or supporting families who are needing some additional support around, internet connectivity and things like that. But we're doing the best we can. But groups it's one that I think about often, because every other month we're like, oh, we just started a new group again. We realize we have a cohort of families who need support, and only one person right now who's perhaps able to provide that service. So why not collectively bring them all together?
Talking about access and reaching people across great distances. And I wonder if you could talk a little bit about what you've found. You mentioned earlier the research that validated home-based, neuropsychology, prior to COVID, and that was published during the early parts of the pandemic. Could you talk a little bit about access and, how you're connecting with individuals and families across, great distances in Texas and perhaps beyond?
Yes, and actually, I don't have it in front of me, but we looked at the mileage range of participants in our study, and it was just from a few miles away to over 2,000 miles away, right? So a lot of folks coming to see us for this specialty care. Now, keep in mind that was a research setting that we were seeing these patients. So when we get into the clinical side of things, of course, there's more to navigate as it relates to licensure in a given state. Some great strides have been made in the field of psychology with PsyPact, where states can opt in to this. Most states have opted in, which allows psychologists to cross those state lines in their work with patients. But it is something that we have to stay mindful of. I am not a part of PsyPact now, but I am licensed in Texas. And so for every virtual visit, I need to confirm that my patient is, in fact, in the same state as I am, where I am licensed, to be able to deliver that care. So I think that it is a piece of things. I also, just kind of going back to some of our previous discussion and thinking about coordination of care, and working with schools and communities. I think there are just so many opportunities we have now that, it's just more commonplace, right? That we're using technology, and it feels like everyone is kind of, for the most part, embracing that. It doesn't always work, to be clear. And like we said, it's not a one size fits all. But thinking about a situation or situations that have come up in our clinic, I work with a multidisciplinary clinic focused on demyelinating disorders. And our patients often have multiple appointments or follow-up appointments. So I would see them in the multidisciplinary clinic, but then at a later time, we might do the full evaluation where they're coming to our office. We often will discover that this patient has multiple visits. Some are virtual, some are in person, ours being in person in the example I'm thinking of. And so I think our clinic has done a great job to be flexible and make sure we can create that private space if they need to hop on with their neurologist for 30 minutes, 45 minutes, and then resume testing, or prior to the evaluation. So I love that. I love that we have the ability to do that for our patients, to make sure that care is not interrupted in another area, another specialty that they need. And then we can help facilitate all of that as we also take care of the service we're providing. So that was just an example that came to mind as we were talking about this.
Yeah. Go ahead, John.
Sorry, and just also building on that, and you had mentioned wondering about challenges. So one thing the field has seen is we technically can reach thousands of miles away, but it doesn't mean that our workforce and our trainees have the experience to work in other communities they have never had experiences with. So there's some very important work that was done in Oklahoma, where a lot of the original telehealth research happened, and working with indigenous populations. And technically, the providers could be uh, sitting right across from new populations that were not currently receiving brick and mortar care, but it didn't mean that the trainees and the clinicians had the experience and the training and the preparedness to provide culturally responsive care that was going to be most effective. So that's an important challenge. I think issues of culturally responsive care get highlighted all the more when working with populations that are not your neighbors. Uh, and then also, it's important as a field, we sort of now think as we see there's sort of one way you look at it, it's so exciting how many people are receiving telehealth care. And then there's this other important question of the rhetoric of telehealth is that we're going to reach new populations. And so it's an important time now that we're about 5 years into the large scale rollout of telehealth. Are we reaching new populations versus how much are we providing convenient alternatives for a lot of the same populations that were already had access to office-based care? And I think we got through the pandemic, and now it's a great opportunity to be intentional in trying to set up and really match the rhetoric, the reality of telehealth with the rhetoric that we can reach new populations. I think that's sort of the big challenge or one of the big challenges for telehealth going forward is can we actually reach and fulfill actualize the promises that are there.
And
What
just
about, oh,
one
please,
more
yeah.
add to that, and what do we do when it isn't feasible or it isn't possible? And what is I was mentioning like the flexibility we have to accommodate things. How flexible can we be if we are setting up a service and let's say there's an insurance barrier or a family prefers to sit in person with a clinician or doesn't have the needed technology and so forth. So that idea of what do we do when telehealth doesn't fit in that situation, or we've even used our clinical judgment that to deliver the results of this assessment, I'd really like to sit in the room with this patient family if I can, and balancing their preferences and the feasibility for the family to participate.
And what about, ensuring that care is appropriate and effective? I think about chatbots and AI and, a lot of the, excuse me, what looks like on the surface, and I don't say to be critical, opportunity to connect with someone or get support and insights through something like that. Does that concern you? Do you see a place for that, thinking about shortages or, even thinking about further bridging gaps between people who need, immediate crisis care or something like that? What would you say to, clinicians or people who, individuals and families who might think, okay, I even getting a telehealth visit, I'll have to wait X amount of time, but this is something I can have access to right now. Any thoughts there?
I think there's a lot of indication that right now we're not there for chatbot therapy. There's a lot of very concerning, you see, a lot of important lawsuits in the news, very concerning current state of chatbot therapy. And, a lot of times with AI models and chatbots, they're trained brilliantly to to give people what they want, to give people the answers that they expect and want. So if you have someone who's depressed, if you have someone, they can work with the logic and get answers that no responsible provider would ever entertain. And so I think, in one sense, this is happening, and we can't hold back the ocean, right? So AI and it's important to work with it, but I think we're a long way from saying that this should be taken as a serious or effective space in formal mental health care.
wholeheartedly agree. Outside of the small children, my teens do, like I said, a ton of trauma and mood work. And even as we're thinking about appropriateness of telehealth, that when it comes to acute risk, our team has a comprehensive DBT program where we do have to think long and hard about the appropriateness of providing services where there may be some additional risk or safety concerns for folks that we cannot see, cannot get to quickly, and making sure that we have the appropriate resources readily available if that is a decision that we're making. But similarly, as I think about the chatbots, I know I find myself and some of our team members as well doing our very best. Like I said, you can't hold back the ocean, but how can we create a small stream, if you will, or slowly build a dam if we can, and trickle out as much as possible. But what is, I think, useful is if we're in spaces, particularly in the telehealth space, that we find that parents or children are looking up things. It does afford us the opportunity to visualize that with them. We can quickly, please share your screen. Let me see what you're taking a look at, and then do as much education as we possibly can as we're learning as we go.
Very helpful. Thank you. Joyce, I wonder if we could talk a little bit more about Project Echo and, kind of your work there, and also just sort of how those clinicians and others in that community are responding, literally to the technology, where and if there are sort of pain points, but also kind of the scope of what you've seen as you've, done that training and helped equip more and more folks with, the skills and the sense of what they, how they can be effective. Could you talk a little bit about that?
Yeah, so our response in the community has been a little bit overwhelming. We had this federal grant to do underserved areas, and that money ran out, and the state said, we really like what you're doing. We're hearing from the providers that we just circling back to that shift from pre-COVID to COVID. One of the things we found that we were doing in these echo sessions, which are designed to be case consultation, case discussion, and then a brief didactic. It's an hour meeting. It's a cohort of people. So it's the same, 10 to 20 people who come over months. And so people get to know each other. They feel comfortable in the space. What we found during COVID was, so we design a curriculum with their input. What do you want us to teach you about? I want to know when it's appropriate to medicate a 3-year-old, or I want to know whatever. Well, what we saw was the topic shifted from, can you help me try to stay sane during this time? Can you help me give me some coping skills so I can give coping skills to family who are not just dealing with toddlers and young children at home, but toddlers and young children who have considerable behavioral dyscontrol, right? So what we found we were doing more and more of, we would hear about the case, but it was more about supporting these providers trying to manage things they were seeing. Even over telehealth, I saw a patient, I was meeting with a mom about her child, and I saw another child climbing on the outside of the stairway in the background while the mother's back was to this child. And I said, turn around, you need to keep that child from falling off the stairwell. So these kinds of things that we provide. But so what we found was when our money ran out, the providers demanded for us to continue. And so we ran for 6 months without funding, and we went to the state and we got people to go to the state, advocate, and say, look, this is a really cheap way to help people manage these things, because they're managing them anyway, and they're quitting in droves because most pediatricians are not equipped to deal with behavioral health disorders. They are required to, but they're not trained to. They'll tell you 75% will say they didn't get adequate training in pediatrics to manage these problems. So from the pediatrician point of view, and then we brought the early childhood people in together with the pediatricians, and they started cross-pollinating. So they would tell a pediatrician, don't request an IEP in the first 2 weeks of school. Give the child time to settle down. And the pediatrician would say, well, this is why I do this. And it was amazing because all these people practicing in silos would come together. And when we did the regional ones, they knew each other sometimes. And we keep confidentiality because it's a consultation, but the participants would say, oh, I think that's a kid in my practice or whatever. So it really, it did, I think it did. The goal of it is to share information, to equip people to do stuff. But I feel like the real goal is the networking and the support, particularly for these people who are in really regional really remote under-resourced areas. And so they have access to each other, and they have access to these experts at the hub who are trying to help them sort these children. So yeah, and we've can continually be funded. Sometimes we don't even write a grant. We get written into someone's grant, which is like 3 of the 5 grants I have right now, I didn't write. So because people are seeing like this is an effective model, it really is a workforce multiplier. It really is support for integrated behavioral health services and expansion into primary care, which the pediatricians want it too. They want to be equipped, and they want the support, and they want the education around it. So we've been really lucky to find this model that I believe it works, and it's also, we save insurance companies money because they're not coming to us, the specialists. They're getting their care in the primary care office, which is much, much cheaper. So, so that's on every end, it's a win-win, I think.
Someone in our audience is actually asking, if one wants to learn more about Project Echo, is there a national organization, or are there sort of regional or local hubs? What would be the best way to learn more?
Yes, so the Project Echo originated at the University of New Mexico. So if you just Google Project Echo UNM, you get their website. It has a dashboard of the 200 countries and 1,500 Echo hubs. So it's a very open and welcome community. Most of the programs are not restricted. The American Academy of Pediatrics is a super hub, and they have echoes not just around behavioral health, but things like epilepsy, diabetes, autism, for providers who are looking for support, who are remote, don't have resources. So, but the Project Echo, because if you just Google Echo, you'll get 1 million hits. But Project Echo with a capital P, UNM, University of New Mexico, there's all kinds of wonderful information. It's been around for 20 years. There's 1,000 publications on its effectiveness. I think it's a fabulous program. We just kind of stumbled on it, and it's now mostly what I do. So
thank you. Yeah, great. We've only got about 10 minutes left somehow, so I want to try to march us through a few questions quite quickly. I want to talk about meeting the needs of different age groups. Earlier on, some of you spoke about the different sort of ages you primarily work with, or age ranges. What works best for a teenager who's very tech savvy might not be the case for a 2-year-old. But I wonder, any insights or sort of takeaways there about when telehealth can be effective with certain age groups or situations, or when it truly cannot. I would assume, maybe it's easier as one gets older, or sort of a non-starter in the early years, but please clear that up for us, or love to hear a sense of kind of what some best practices are there.
Well, I'll say that a lot of the work that I do is with young kids, and we find the telehealth format works wonderfully because with younger kids, you really want to work with the parents because you're sort of in treatment. You want to reshape the home environment and the interactions. So when we developed internet delivered parent-child interaction therapy, so PCIT is a very well supported format for treating behavioral challenges, relational problems, and more recently anxiety, traumatic stress, and even depressive symptoms in young kids. And what you're doing is, kids are too young to work when you're working with young children. They're too young to be the direct target of treatment, and so we indirectly work with them by reshaping parenting practices. The original model is the bug in the ear model. So the family comes in behind a one-way mirror, and the therapist is behind the one-way mirror providing live coaching, parent coaching to the parent through a sort of a walkie-talkie earpiece. Decades of research supporting that model. So when we adapted it for the internet. This is what we were doing actually before the pandemic, but that's the trial where we compared it to office-based care. And we have families at home, Bluetooth earpieces. The kid doesn't even know the parent is listening to someone in their ear, sort of unobtrusively being a secret parent whisperer in the home, and live coaching parents. So that format works beautifully for young kids because you don't want the kid to even know or remember that there's someone with, sort of coaching mom or dad through how to navigate these home interactions. So in some ways, I find it uh, easier to work with younger kids because you're really focusing on the parents. And then, of course, with the older kids, the teenagers are teaching me how to use the technology. So that's helpful because they're also the IT support for the session.
Erin, did you want to add something?
Well, I know for young children, hands down, it could be incredibly useful. But I think about some of my older children where some of the work that we're doing is really, you're needing to get moving right now. And so instead of saying, they're at home, if we're talking about cleaning the room or moving or organizing, we're doing it right now. We're not going to wait until you get home. And so I've found it to be incredibly useful for older children where, we're dependent on, from a brick and mortar space, them remembering, being motivated enough to, follow through with some interventions once they are home with or without parents. But here we can navigate that a little bit differently when we are truly in the space. If we need to add something to a calendar, take me to the calendar, log it right now. That it is a unique way of doing really live interventions.
I would just add with the little ones, I found that doing new assessments was too challenging. You could do intervention, I could do med visits with my established families very easily and very nicely. But I found that when I was seeing a patient for the very first time, I could not get a handle. At first I thought, oh, look, this 3-year-old is like so engaged. They're staring at the camera. They were looking at themselves. They weren't at all engaged with me. And so I'm often tasked with trying to figure out, is this autism or is this not? And I really need to be in a room with a child when it's subtle and when it's mild, to get that. Is there that connection? Is there that interpersonal connection? So I stopped seeing new kids, but I would see kids who had been seen by other colleagues who I trusted, so I could say, tell me what this kid was like in the room. But that was my only hesitation. But otherwise, the ongoing treatment, I agree with both you and John. It's especially because so much of it in the younger kids is directed toward the family and with the family. It's very easy to make that shift. And I don't like teenagers, Erin. I know you're tots and teens, but I stick with the little ones.
We have one more audience question, and then I want to make some time for final kind of comment from each of you. Audience member asks, simply but genuinely, sincerely, what platforms do you use? Or, are there specific kind of technical tools that might not be familiar to folks that they should kind of keep an eye on? And, I don't know if between Zoom or other outlets, anything special that someone should be mindful of that they might not be familiar with?
Whatever your lawyer tells you is okay.
Very important.
Whatever
That's a great one.
hospital administration wants you to use, or
yes, whatever they. Down here in DC, we recently transitioned to a new telehealth platform that it's integrated into the medical record, and it's actually offered a couple of really great benefits. One of those is families only go to one place. They're not looking for individual Zoom links for individual providers. It is attached to the child's chart. And what that also allows for our multidisciplinary clinics is, again, everyone's not looking for the same Zoom. Providers can pop into meetings or pop into virtual visits with ease without needing anything other than entry into the EHR.
I want to close this out. I don't want to close this out, but we're nearly at time. There's a lot we couldn't cover or go into even greater detail on, but I just want to give you each the opportunity to either reinforce something or mention something that maybe we haven't talked about over the course of the hour. Erin, maybe we can stick with you and
sure. Since I'm here, I think the beauty here is we are revolutionizing, if you will, the interventions that we're able to offer, and whether that's by expanding our workforce and capacity and providing training and actual direct care. And so, think through where the tough spots are, and we can, again, there's a lot of collaboration that's happening across the board. I think all of us are describing a lot of collaboration. And if you're feeling a bit in a silo, know that there's a group somewhere somewhere and that are probably more than willing to help and support or find creative ways of expanding the work that you're doing.
Joyce?
I would echo Erin and just say that ECHO really is a way to bring people together, to make networks, to do the work, to expand the workforce, and to expand what people can do. And they're really easy to do. They will train you virtually. New Mexico, if any of you all who are on this want to do it, go to the website, look at the training, and think about doing it where you are, especially if you're a specialist, a behavioral health specialist. There's lots of people who need your expertise.
John?
I'll just say that hopefully people what it is, necessity is the mother of innovation, right? So like I think there was some resistance before the pandemic, but now it's out, it's hard to put the toothpaste back in the tube, and people are realizing but that it's not just a sort of carbon copy of office-based care, that when I think it's best when we think about what new options are there and how does this fit with still a very important role for office-based care, these hybrid models, and not thinking of it as like a horse race model as much as which formats for whom are going to be best for which kids.
And final word from you, Lena.
Sure, yeah. I mean, I think echoing all of you, I think it's an exciting time with these tools that we have right now. And I think to an earlier point, I think we're all figuring it out, and it's wonderful that we have each other, we have our research, and all these great programs that we've been talking about today. And I always, whenever I talk about this subject, and we've alluded to this already, it's not a one size fits all. And I think that behavioral health in particular, providers really do a great job at tailoring all of our services, and that it's no different when making a choice to use telehealth, that we are tailoring that approach for the patient and family in front of us. So I think that would be the last thought that I would want to share. Thank you.
Thank you, and all of those are important takeaways. I know I'm leaving feeling very encouraged and empowered, and I hope many of you who joined us in our audience are doing the same. I want to thank our panelists, Dr. Lena Harder, Dr. Joyce Nolan Harrison, Dr. Erin Sadler, and Dr. Jonathan Comer for their time and their insights. Thank you to those of us who were live with us with some good questions. A recording of today's event will be shared in the coming days, and please don't forget to visit usnews.com/events for more information on upcoming events. Thank you all, and see you next time.
Thank you.